fast, have no financial interest. So as we all know, glaucoma is the leading cause of irreversible blindness worldwide. And the importance of identifying glaucoma cases is equally important, especially in the remote areas where conventional perimetry is not readily accessible. So the HFA 24-2 CETA program is widely accepted in patients with glaucoma and is considered as a gold standard. However, it is expensive, mainly for some general practitioners, not portable. A data export is needed for the analysis. There is definitely a learning curve for the beginners, and it is difficult for those with mobility issues. There comes the relevance of Melbourne Rapid Fields. It's kind of an amalgamation of technology with science. It is the first iPad-based perimeter in the world. The purpose of the study was to compare the results obtained using MRF and HFA 24-2 CETA fast in glaucoma patients. And this is the first study in South India as a part of a major validation study undergoing worldwide with an exclusive study population of Asian origin. It's a cross-sectional observational study. These are the inclusion and exclusion criteria. This is a numerical scale when you compare MRF on the left side with 24-2 HFA on the right side. So you can see there are few extra points in the central 10 degrees in the paracentral area on the MRF. So cumulative 66 points are analyzed in MRF, whereas 56 are analyzed in the HFE. So the suitable iPad models are any iPad with a 9.7 inches or more. Initially it was designed only for Apple products, but now it is available in Android products also. The software license is around 20,000 Indian rupees, and the test package comes in a multiple of 80 to 100 tests for around 20,000, and this definitely is a cost effective, and the price may vary based on the type of practice. Now the test has to be performed at 33 centimeters for a 9.7 inch tap. So if you are doubtful about the patient position or head movements, you can use a viewing shield, which is optional, and the response is documented by either tapping on the keyboard or by tapping the touch zone. There is a web-based software which is available now. I'm doing a study on the same with which can be done even on a desktop PC or any personal laptops, and there is an offline option also which will be useful in the remote areas. So the protocol used here is a Bayesian protocol, different from the bracketing strategy in CETA fast or CETA, and it covers 30 degrees horizontal and 20 degrees vertical. The initial normative database included 400 people living in Australia, with out of which 35% were Asians. So this is how it looks like. Initially you have to log in like any software app. These are the tests available. Here we have used full test, that is a radial pattern. The fixation point comes in the center, and there will be stimulus displayed elsewhere. So you can either touch on the tap zone, or you can use a keyboard spacebar. Now if it's a small screen, the fixation point moves to all the four corners. If the screen is big, then if it is more than 12 inches, then there will be only one fixation point like in an HFA. And to counteract the tangent effect of the flat screen, the stimulus size increases towards the periphery. This is a printout. It's almost similar to an HFA printout. The only difference is the VFI is named as visual capacity here, and the GHT is replaced by a color-coded indicator. These are the outcome measures. These are the statistical methods used. So 30 eyes of 30 patients were included with a mean age of 62 years. ESD, visual field index, and test time were almost similar. However, there were significant differences in mean deviation, foveal threshold, and points on PSD probability plot. Out of 26 cases which were diagnosed as outside normal limits in HFA, only 22 were diagnosed as red in MRF, which points the possibility of missing some early glaucomatous defects. Reliability indices showed no significant difference. There was strong correlation between the parameters on both the programs. So the test time of MRF was almost similar to CETA fast. Definitely it is 1 to 2 minutes lesser than the CETA standard. The lower MD with MRF could be due to difference in the number, size, location, and duration of stimuli, and the difference protocol used, and difference in the normative database. VFI and VC were almost similar, and definitely the significant lesser number of points with MRF point towards the possibility of missing early cases of glaucoma. Blind outline plots confirmed lower MD and few test points, and this could be due to variation in the study group or participants. So MRF is definitely easy to perform. It's cost effective for a general ophthalmologist, device independent and portable. Data can be exported and multiple tests can be performed at a time. However, yes, it has its flaws. So a definite effective tracking system is not available now for monitoring fixation loss. That should be made available, and inclusion of more regional languages would be useful. So it's the first study in South India with an exclusive study population of Indian origin, comparing more perimetric parameters and identifying new aspects or limitations. And definitely it has a limitation of a small sample size now, but we are increasing the numbers as a part of a major validation study undergoing, and it's a cross-sectional design. To conclude, despite using a completely different program, MRF provided reasonable outcomes to HFA. It is definitely cost-effective, time-saving, and user-friendly, and will be better for community settings as a screening tool, where you can actually refer the cases to a glaucoma specialist for further analysis. Even though some early glaucoma cases may be overlooked, detecting moderate to advanced glaucoma at a fraction of the cost in a remote community justify its further refinement and use. This is no way a replacement to the gold standard HFA, as it's a new technology. We have just compared the thing with the gold standard HFA. Thank you for your kind attention.
It will be better if you have Indian eyes in the database because it's Asian.
Yes, sir.
And
Actually,
so Asian is actually, the Mongoloid population, so to say.
yeah. So actually, when I asked the manufacturer, so what he said is like in Australia, they had a few Indian population also, but still the numbers are very low. That is why what we are doing now is trying to validate it with more number of Indian eyes. So initially in 2019, we have done a pilot study when I was in Delhi under Dr. Harsh Kumar, and that was comparing with Sita standard. But at that time, the software had many flaws. Like there were a lot of things which were not available. It was not available offline. So they had a lot of issues with the software, which they later updated. So since last year, we are trying to get more patients to see whether we can validate. So definitely we need more numbers from Indian eyes.
And also the display has so much of variation. For example, even if it's a 9.7 and above to a screen, each pixel will be a little different. Then how do you compare between,
Yes,
let's say,
actually,
desktop version to a iPad version? And how do you get the
so actually
continuous?
the whole viewing distance, everything changes with the size of the
True.
monitor.
Yeah, yeah.
So in this study, we have used 9.7 inch. That is why the fixation point moves to the four corners. So if you have a desktop screen, or the more bigger it is, then the more it becomes like an HFA. There will be only one central fixation point. The only issue is it is not a bowl. So to counteract the tangent effect of the flat screen, what it does is the stimulus size starts at 2 in the center, then towards the periphery it increases. And another issue is the background luminance, but the engineering or the manufacturer says they have actually made it in such a way that it is basically the contrast ratio between the background and the stimulus is what matters. So, and whatever results we got, other than missing some early cases, it definitely worth using as a screening tool.
The other thing is like the ambient, apart from the system lighting, the ambient light also plays an important role
Yes,
in the
actually
room.
it should be done in a dim lit room, and the screen should not have any reflection. So it should not be done near a window where there will be a reflection on the screen. So the screen should be devoid of any reflections, and it should be done in a dimly lit room. That is why there is this option of a viewing shield also. So if you want to use that, then it becomes more easy. But the problem is again the patient has to bend the neck. That is sometimes difficult for some patients. So yeah, the ambient light is a factor. Though there are studies which say like there is no difference between dark room and light room, we personally felt dark room is needed.
So do you have a separate room to do this?
No, ma'am, we do it in our perimetry room only. So it will be dark. So, and if one of the OPDs doctors are not there, then we can use the same desktop PC also. That is a different study, like it is a web-based software. Here we have used
But
the
then you
iPads.
said no illumination. So in the desktop, in the OPD, you have to make it dark,
Yeah,
right?
yeah, we have
The
to close
illumination
the
should be the
windows.
same everywhere
Yes,
if you
yes,
compare, right?
yes, ma'am, yes, ma'am.
And second thing is, you said you did a pilot study. Is it
Yes.
with the latest version or with the earlier version?
No, it is the earlier version. It was done in 2020.
Okay.
That was just 28
So there
eyes.
is no validated data for the Indian eyes as such, or
No,
this
ma'am.
is the
No, ma'am.
validated.
Yeah. So I think RP Center, Dr. Vinay sir is doing one study parallelly. So he has done in few pediatric eyes. So pediatric eyes he has published, and it is almost reasonable outcomes. But adult eyes, we are on the process. We are just collecting more data so that we will see whether it can be validated. Till now, we are not very sure about it.
So maybe you should have an age match control also.
Yes, ma'am. Like
For the
in this,
normalize.
yeah, we have a definite control for normalize also. So here I have just included glaucoma patients, but
Exactly.
otherwise, and even mild, moderate, severe, we are actually classifying. But the one issue which comes is the Anderson criteria is actually applicable for the HFA. So we can't actually put the same criteria for MRF and term it as mild, moderate, and
No,
severe.
that's
That is,
because you have rechanged the design of the layout.
yes, sir,
Yeah,
yes, sir.
that's
That
because
is
you have
one
put the spots all over the places.
exactly,
So you
sir.
cannot put the Anderson's criteria there.
Different
So it's
protocol also.
yeah.
Moving all over.
The other thing is your brand element. You're not told what is a confidence interval. It's all over the
Okay.
place. Actually, it's quite
Yeah, it's
wide.
actually
Yeah,
the
upper
mean
20.
deviation and the number of points on PST probability plot, it's actually very wide.
Yeah. So
So
even otherwise, the uh, the intervals are quite.
yeah, there are outliers also,
Yeah.
the significant
So
outliers.
the issue with this is I think the sample size.
Sample size, yes, sir. We need to
Sampling is
increase more
yeah,
numbers.
yeah. So this
So
even the
that only
published
becomes
ones are very less samples.
less samples, yes, sir.
28, 30,
Yes,
something
sir,
like
yes,
that.
sir.
It's not going anywhere actually.
Exactly. But
All the
now
pub.
there initially there are a lot of issues, ma'am. Like this, they are told the viewing shield is mandatory. There was no web-based software, and there was no offline methods. And but once we told these suggestions, they have included a lot of things. They have tried to
No, if you're
change a lot
making
of
so
things.
many things, then the idea of doing it at home, it's defeating the purpose. Then you have to have it
Yes,
in a
you
monitored
have a
way.
lack of
Then
support.
yeah,
Yeah.
then you have to compare it
For
with the.
fixation loss, what they say is they are actually checking the blind spot in the beginning with the stimulus, but still it's better if we can
So
actually
you should have a
monitor it.
tracker. Yeah.
Okay,
Thank
thank
you.
you.
Thank you, thank you.
Good morning. My topic is on factors affecting adherence to anti-glaucoma medications in a tertiary center in North Kerala. Glaucoma is a chronic progressive optic neuropathy leading to irreversible blindness worldwide. Lifelong topical medication is the cornerstone of management. The major challenge in glaucoma treatment is adherence to medical therapy. Non-adherence itself is a risk factor for progression, hence it is important to assess the factors affecting adherence. Very few studies from Kerala addresses adherence patterns. There is limited exploration of caregiver role and socio-economic factors, limited exploration on accessibility to healthcare and medication availability. Interventional studies are lacking. Aim and objective to determine factors affecting adherence to topical anti-glaucoma medications in a tertiary center in North Kerala, to evaluate the relationship of adherence behavior with patients' demographic data and socio-economic status, to evaluate measures to improve adherence to anti-glaucoma medications. Materials and methods, study site, Glaucoma Department, Comtrust Eye Hospital. Study population, glaucoma patients on topical AGM for at least 3 months or more. Study design, cross-sectional questionnaire-based study. Patients on AGM for at least 3 months and aged over 35 years who gave informed consent were included in the study, and patients scheduled for glaucoma filtering surgery, patients with cognitive impairment or psychiatric illness were excluded. Methodology: a semi-structured questionnaire used to assess patient-reported problems and glaucoma medication adherence was distributed to the patient. Brief medication questionnaire is a validated tool for assessing glaucoma medication adherence. This was translated to local language and administered in a structured and standardized way. The questionnaire included demographics, socioeconomic profile, knowledge, attitude and practice, adherence behavior, barriers and methods to improve adherence. Adherence was defined as not missing more than 1 day drops in past 15 days on subjective assessment. Coming to the results, total sample size was 380, which included 180 males and 200 females. Demographic details: 86.8% of the participants were between 45 to 75 years. 58.4% came from more than 25 kilometers from the hospital. 65.5% were unemployed. 81.3% had education more than 10th standard. 96.6% had caregiver with them. 63.3% was on single AGM, 27.6% on 2 AGM, and 9.2% was on more than 3 AGM. This is a graph showing distribution of subjects based on AGM use during the last 1 week. 79.5% were adherent. The barriers to adherence, non-adherence identified were cost 33.2%, forgetfulness 18.4%, difficulty in obtaining medication 16.1%. Suggestions on how to improve adherence were cost reduction 40.8, tele reminders 25%, and 18.9% opted to make medicine available at peripheral pharmacies. Regarding caregiver and adherence, with caregiver adherence was 79.8% and without caregiver adherence was 53.58%. So the adherence was significantly influenced by caregiver support. AGM adherence and distance from hospital. Adherence was significantly influenced by distance from the hospital, underscoring the importance of availability of medications at peripheral pharmacies. This is a trend analysis on AGM adherence versus distance from hospital. The blue indicates adherent population and red indicates non-adherent population. The large negative Z value indicates the strong decreasing trend in proportion. So as the distance from hospital increases, the percentage of adherent people decreases and non-adherence increases. So this suggests that greater travel distance acts as a barrier for consistent follow-up and medication adherence. We also studied regarding association of AGM adherence with other parameters like age group, sex, education, and number of AGM, but none was statistically significant. So our study reaffirms that even in a high literacy state like Kerala, adherence is determined by multiple social determinants. So our study with a comparatively larger sample size of 380, adherence was 79.5%. Our observed adherence was comparatively higher when compared to other study, probably due to strong caregiver support. The major barriers identified were cost, forgetfulness, and difficulty in obtaining medications. This was almost similar to other studies conducted by Singh K. et al. And Sleep B. et al. In our study, adherence was significantly influenced by distance from hospital and presence of caregiver. Strategies for improving adherence included cost reduction, tele reminders, and improved local availability of medicines. A study conducted by Rajurkar K. et al. In North India, he emphasized reminder systems like SMS and app, patient counseling for as a method of improving adherence. At a global level, results align with studies conducted by Kebede B. et al. In Ethiopia. However, their adherence were 45.8%, possibly due to old age, low education, longer duration of treatment. So our study concluded that adherence to anti-glaucoma medication was 79.5%. Cost, forgetfulness, and difficulty obtaining drugs were main barriers to adherence. Caregiver support and proximity to hospital were significantly associated with better compliance. Targeted strategies like cost reduction, tele reminders, improved access can improve adherence. So this study adds to a regional insight. This provides one of the large-scale adherence study in North Kerala, identifies modifiable barriers to adherence, demonstrates a significant correlation between distance from hospital and caregiver presence with adherence, supports integration of tele reminder systems, cost reduction, local pharmacy, drug availability into glaucoma care programs. So limitations are self-reported adherence was used. So the responses may be affected by recall bias, which may not reflect long-term compliance trend. Study did not assess visual field progression or IOP outcomes to correlate adherence with disease control. Medication cost variability, drug availability difference between urban and rural participants were not separately analyzed. Structured questionnaire assessed only short-term adherence. So the recommendations put forward are increase access to affordable AGM at peripheral pharmacies to reduce travel burden, introduce mobile-based reminders, encourage family support in daily administration. These are my references. Thank you.
You spoke about the socioeconomic status, right? So did you assess the socioeconomic status and how did you do it?
By Kupuswamy scale.
Kupuswamy, will show it, I think, right? Okay. And then did you validate the questionnaire that you had used?
Actually, brief medication questionnaire is a validated questionnaire, but we have locally validated it in Kerala.
So you have a pilot study for
yes,
that?
we have done pilot
How many
study.
cases were there in the pilot study?
40 patients we have taken.
So they are included in this or they were excluded from this?
No, we have included that also in this.
Into this, okay. And then adherence, you said no adherence. So what is the difference between adherence and compliance?
Adherence is an active process, that is act of doing it willingly, whereas passive is what compliance is a passive procedure. They are supposed to do what what doctor has been advised. It's specifier.
So you said even if missing 1 day is non-adherent, right?
Yes,
1 day of the dosage also is non-adherent.
non-adherent.
Okay. And then multiple AGMs, you said that it's causing non-adherence, right?
Yes.
So did you try with fixed combination? Did you categorize them as fixed combination monotherapy or whatever it is? Or you put just anti-glaucoma drops and you looked at the adherence, that's all?
Just anti-glaucoma, we have even with multiple drops.
Like concomitant therapy. Concomitant therapy is 3 medicines,
Ah.
and then fixed combination is having all the medicines in one bottle, right?
Yes.
So
No, we
did you
haven't.
check that fixed medicine has got more adherence, or concomitant medicines has got more
No,
adherence?
no, ma'am.
You didn't check it. Okay. So it will be better to check that. That will give you more idea whether the patient is compliant to fixed combinations or concomitant medications, because that will reduce the cost also.
3 months is a very short time to assess adherence, no? The patient, if you had a patient who was following up for 1 year, 2 year, that makes more sense rather than looking at a person who is just into the medication for 3 months, sorry. 3 months is extremely short. Sometimes even you may
For them to
reconsider
even
the,
understand about the disease, it's like
Yeah.
takes months.
and you have not asked questions related to their fear of blindness and things like that. That aspect has not been covered, I feel.
And you said you asked about KAP, right?
Yes.
So KAP was done twice or just one time?
One time only, ma'am.
So one time is also a very short duration. Like, you have to give the KAP. They seem to appear knowledgeable after the KAP, but after the second visit, there is a limitation, like, it decreases again. So, and as you said, 3 months is a very short duration.
Thank you.
Next presenter is Dr. Natasha Radhakrishnan.
Good morning, dear judges. My topic is intraocular pressure in premature infants. What is normal? I have no financial interest in the machine used. Understanding normative IOP value in preterm infants is crucial, as deviation may affect visual development or indicate congenital ocular disorders. There is paucity of standardized data on IOP in premature infants, as well as its correlation with post-conceptual age, birth weight, and presence of ROP, especially in the Indian population. With the portable rebound tonometer such as the eye care, non-invasive IOP measurement in this population has become feasible even in the intensive care NICU setting. The aim was to determine the normal intraocular pressure range in premature infants using the eye care 200 rebound tonometer. The primary objective is to establish normal IOP ranges in premature infants, and the secondary objective was to correlate it with increasing post-conceptual age, birth weight, and presence of ROP. It was a multicentric longitudinal study, 60 eyes of 30 premature baby infants with gestational age less than 34 weeks were evaluated as part of a routine ROP screening program in the neonatal NICU unit across different hospitals in the Ernakulam district of Kerala. The post-conceptual age is gestational age plus number of weeks since birth. The infant was laid on his or her back in the incubator, and IOP was measured with an iCare IC200 rebound tonometer without the use of speculum. Right eye was examined first in all cases, and measurements were obtained between 9 a.m. and 12 noon. 3 IOP measurements were taken for each eye, and average IOP calculated and was repeated after 2 weeks. So these were my inclusion and exclusion criteria. In the results, in the baseline characteristics of the study participants, the the post-conceptual age ranged between 29 to 34 plus 2, with a mean of 31 plus 2. Gestational age 26 to 31 with a mean of 27 plus 6. Birth weight 1000 to 1890 with a birth weight average of 1421. And the categorical variables, the post-conceptual age was divided into 29 to 30 weeks, 31 to 32 weeks, and 33 to 34 weeks into 3 categories. And these were the numbers in those categories. The ROP, any grade, we did not divide depending on the grade of the ROP. It was just presence of ROP or not at this particular stage of the baby. And it was into yes and no. The difference in IOP between baseline and after 2 weeks if you take all the eyes together, the mean IOP was at baseline 15.13, and after 2 weeks it reduced to 14.64 with a difference of 0.49, and this p-value was found to be significant. So there was a significant difference between baseline IOP and IOP after 2 weeks. The comparison of IOP with post-conceptual age in both eyes and its difference after 2 weeks, what you find is that the baseline IOP is higher in the lower age group compared to the higher age group. And a decreasing trend in IOP was noted in 3 groups after 2 weeks, but only group 1 was statistically significant. Comparison of IOP with presence of ROP was that significant difference in IOP in baseline values were noted in the babies who had ROP irrespective of the stage of ROP, and this was also found to be statistically significant. Comparison of intraocular pressure with birth weight, infants with lower birth weight showed a significant decrease in IOP values from baseline after 2 weeks, which means baseline, the measurement in the lower birth weight babies had a significant difference after 2 weeks when we measured the intraocular pressure. This is the correlation graphs showing a significant negative correlation between baseline IOP and post-conceptual age, and a significant negative correlation between after 2 weeks. This is baseline IOP and birth weight, and this is 2 weeks and birth weight. So various studies have been conducted to assess IOP in premature infants. Most of them were cross-sectional analysis, and very few longitudinal analysis has been done. The most recent longitudinal study by Monteira et al. In Portugal demonstrates that with a mean gestational age of 29.4 and a mean birth weight of 1,222, mean IOP showed reduction every 2 weeks till the post-conceptual age crosses 37 weeks. Our study had a larger sample size of 60 eyes of 30 preterm babies, and we found that the IOP reduced after 2 weeks from 15.13 to 14.64, indicating a similar declining trend as in the previous study. We obtained a significant negative correlation with post-conceptual age as well as with birth weight. These are the related longitudinal studies that I have looked into, but most of them used a different instrument. The instrument used by the Monteira et al. Study is what is we have also used, but that was a Caucasian population, and this is in our Indian population. But in all the studies, we can see that there is a declining trend, especially in the lower gestational age and the lower birth weight babies. The physiopathological mechanisms that explains this consistent IOP decrease is the increasing size of the ocular structures, anterior chamber angle maturation, progressive improvement of the aqueous drainage system, and neuroendocrine changes. Some advantages of our study is that we have not used an eyelid speculum, and none of them were sedated or given muscle relaxants during the examination that may interfere with the result of the IOP measurement. So in conclusion, mean baseline IOP values in preterm infants in a South Indian population was 15.13, that reduced to 14.64 after 2 weeks. Baseline IOP is higher in lower gestational age and lower birth weight infants, and a decreasing trend in IOP is noted after 2 weeks. Significant decrease was found with the presence of ROP, which correlates with the lower birth weight and lower gestational age. We do not give it any other for more significance. And to our best knowledge, this is a pilot study in Indian population to record the normative data of IOP in preterm babies. These are my references. Thank you.
This was a retrospective study or prospective study?
Prospective study.
Prospective. With and ethical considerations and all, they were all considered.
Yes.
What would be the reason for our population having a low IOP compared to the other population which has been mentioned in the literature?
We really don't have, for the baseline decrease, we don't have a explanation, but it could be that our population included lower birth weight babies also. So it was not exactly comparable, the babies that they have.
And
because this was based, a lot of the data is from infertility centers, so there was very preterm babies as well.
So we use the right eye for all the evaluations?
No. Both eyes, but right eye was examined first.
Okay.
Because just to, because there's crying for the baby when
Right.
there'll be some disturbance. That's
So
all.
wouldn't it be better if we had no ROP and then just evaluate the right eye? or babies
Just the,
which, yeah, because here you'll have duplication.
Okay.
You'll have 60 plus, you'll have the IOP as magnified,
Okay.
and the lower IOP will show more lower than what was in the literature. Because although the advantage here is that we have not used the speculum, the other studies have used the speculum. Almost all of them, many
Except
of
the
them
Montera. Actually, the iCare 200 is the only device in which you don't need a
need a
speculum.
speculum. Yeah, so the the tonopen and all would have definitely required the
Definitely,
speculum.
yes.
But if you add the eyes and then present the IOP, it shows a magnified view. So if you're looking at IOP reduction, usually the drug trials which we
No,
go
here we have not added the eyes. We have looked at right eye and left eye separately.
separately.
Oh,
Okay.
yes, yes. Left eye
So-
is also included. It's just that methodology,
Yeah,
we
so-
have mentioned that right eye was examined first.
First, yeah.
That is
So
all.
when you add right eye and left eye, so the sample size sort of increases.
Yes.
So it'll give you a, but it's patient centric.
Patient.
It's not eye centric. So patient centric, if we talk, then it will be showing that our patients have lower IOP. There's the artifact which is put into the bias which has been put into the study.
You have examined the patient only one time, or how many? What was the duration between the two weeks?
Two,
So
2
why
weeks.
didn't you put the grading of the ROP? Did any children require laser or
They
treatment?
were removed from the calculation.
Totally
Yeah.
excluded. Only no ROP patients. You have looked at whether the normal physiological. That's all.
Treatment
So
is
it's grade 1 and grade 2, or no ROP.
Yeah, it is divided into no ROP and patients who had any
So ROP 1 and 2.
Stage 1 and 2, yes.
Stage 1 and 2.
Yes.
That's what I'm
Yes,
asking.
not
So stage
requiring
1 and
treatment.
2 and no ROP were included.
That's
You have excluded from 3, 4 and 5.
3, 4
right?
and
Okay.
3, 4 and 5 ഒന്നും ഇല്ല madam. 3 ആവുമ്പം treat ചെയ്യും. So patients who needed 3 were excluded.
Okay. So
And
that,
we have measured the IOP 3 times. So to avoid to get the inter-observer, that is each time 3 times.
The better way of evaluating them, not making them cry or something like that. How to?
These babies require only swaddling, because once they are swaddled and they are comfortable, the instrument itself doesn't cause much trauma. And because there is no speculum, no paracane application, generally they are comfortable.
Thank you. Thank you.
Thank you.
Our next presenter is Dr. Mohinda Mohan.
Respected judges and good morning everyone. So we'll discuss about the comparative analysis of loteprednol 1% and prednisolone acetate 1% following ND-YAG peripheral iridotomy, a prospective observation study. A laser peripheral iridotomy is the procedure of choice for angle closure glaucoma caused by relative or absolute pupillary block. LPA eliminates pupillary block by allowing the accused to pass directly from the posterior chamber to anterior chamber by creating a small opening in the iris bypassing the pupil. LPA can be performed with an argon laser, with an ND-YAG laser, or with both. While the procedure is highly effective in lowering intraocular pressure and preventing further optic nerve damage, the transient post-procedure inflammation is a common concern. Topical corticosteroids are used after ND-YAG iridotomy to suppress inflammation and minimize this complication. However, their comparative safety profile remains an important clinical question. So the purpose of my study is to compare the safety and efficacy of 1% loteprednol eye drop, a soft steroid with a favorable safety profile, with 1% prednisolone acetate, a strong steroid after ND-YAG peripheral iridotomy. So we included all the patients who were diagnosed as primary angle closure and primary angle closure glaucoma based on International Society of Geographical and Epidemiological Ophthalmology classification and were above the age of 40 years, and excluded history those who were having history of uveitis or active inflammation, non-steroid responders, prior ocular surgery in the study eye, and allergy to study medication. Informed consent was obtained from all the patients. The study was conducted at Contrast Eye Hospital, Kozhikode, from November 2024 to May 2025, and patients were 274 eyes were analyzed, and patients were given lots and were divided into 2 groups. Each
group contains 137 eyes. And the group 1 received loteprednol etoposide 1% for BD, and group 2 received prednisolone acetate for QID. And initial setting of 2 millijoule, then increased to 4 millijoule until iris was fully perforated, followed by gush of aqueous was seen. And follow-up was done after 1 week and 1 month. And the primary outcome measures were anterior chamber inflammation, which was graded based on Sun classification. IOP was measured using Goldman applanation tonometry. And secondary outcomes include rebound iritis, ocular discomfort, patient-reported symptoms. And the statistical method included chi-square test, and a p-value of less than 0.05 considered statistically significant at 95% confidence interval. And the demographic characteristics of the study population, in which age, gender, initial IOP were comparable between two groups. Anterior chamber inflammation at 1 week showed slightly higher inflammation in loteprednol group, but it was not significant. The mean baseline IOP was comparable, and after 1 week, prednisolone group showed slight elevated IOP, and after 1 month, values become almost identical between the groups. Rebound iritis occurred in 4.4% of loteprednol group, and in prednisolone group it was 10.9%, and p-value was 0.03. It was found to be statistically significant. Coming to the discussion, according to Stephen S. Lane in his study, he found that inflammation control was equal and effective between both loteprednol and prednisolone group. And in our study, both loteprednol and prednisolone were effective in controlling post-PI inflammation. These are the studies in which loteprednol has a lower tendency to elevate IOP compared to traditional corticosteroids like prednisolone and dexamethasone. And in our study, over 1 month, both loteprednol and prednisolone caused only a minimal increase in IOP. However, prednisolone showed a slight higher IOP at 1 week and 1 month, supporting the view that loteprednol has a safer IOP profile. And by Kirti Gayam et al. In 2020, in their study, they found that rebound iritis occurred in the prednisolone group after ND-YAG-PI. This supports the fact that rebound iritis as a complication after YAG-PI and is more likely with stronger steroids, consistent with our finding that loteprednol had lower rebound rates. So to conclude, in prospective settings such as post-ND-YAG-PI management, loteprednol 1% provides similar anti-inflammatory benefits to prednisolone acetate 1% and less likely to cause clinically significant increase in IOP. And the limitations of the study are a questionnaire on post-procedure pain, patient discomfort would have been added. ASOCT measurements of iris thickness may have included, and it has relatively short follow-up. These are my references. Thank you. Yes, sir, but
That has not been presented. Methodology, there's a mention
Yes,
which you
sir.
asked. Yeah, that's very important because when you do these lasers, then you will invariably ask about patient related. And what is the protocol for using prednisolone? How many days? What was the
both the steroids were used for 1 week, sir.
1 week? And then it was stopped, and then you check the rebound inflammation at 1 month also.
Yes, sir.
1 week and
1
1
week
month.
and follow-up was done after 1 month.
So first, prednisolone showed a higher rebound iritis. Can you tell me the protocol for the nepafenac use in the Kirti Gayam study? Do you remember that? It's a very complicated protocol for NSAID. It's not a very straight. How many times would you use NSAID? If you were to do the study with nepafenac, how many times would you use NSAID?
QID.
Yeah, usually it's TID, and but they had 4 times, and then they shifted to 2 times, and then it went on for almost 2 to 3 weeks. So it was a very complicated protocol for NSAID, whereas the prednisolone was straightforward. How would you prevent rebound iritis if you were to? Why does rebound iritis actually occur?
Sir, the prednisolone, since it has a ketone group, it's a strong steroid. It reduces the inflammation, and it also suppresses the body's immunological factor. Whereas loteprednol, it suppresses the inflammation in a weaker way. So on after withdrawing the prednisolone, it will rebound. Thank you.